And
Absolutely.
so, I mean, this is going to be, and you're going to see, and this is kind of what we're talking about today too. But you're going to see that and you saw it at the MGMA conference.
Oh yeah. Yeah. People are getting
Everybody
squeezed,
was burnt out. And why
burned
was
out.
everybody burnt out? Because admin keeps getting the shaft.
Admin keeps getting a shaft and employee turnover. Huge.
uh, Admin getting this shaft. You know
Yeah.
what I mean? Like,
Yeah.
there's no way. It's amazing. But we can really dive into some of the reasons, but then we have to have the conversation of whether it's cause or effect, right?
No, absolutely.
Um. So let's you want to
Yeah,
you
we
want to
can.
jump in?
Yeah, we'll dive into it. Good afternoon, everyone. Welcome to today's webinar session. Today's topic, we're going to be discussing, as Jose mentioned, downsizing in healthcare, understanding the industry's workforce reductions going on in today's world. I'm Ray Walters. I'm with Epi Compliance. I'm joined by my co-host, Mr. Jose Delgado. For those of you that might be tuning in for the first time, Jose has 20 plus years of experience in healthcare consulting, currently owns and operates a mental telehealth clinic. Has a lot of knowledge with these things, and obviously he sees a lot firsthand as well, working with the clinic. Yeah, like I said, we're gonna be talking about workforce reductions. We have a couple case studies we do want to share with you guys. I think there's a couple articles that you sent me, Jose. I'll throw them in the chat.
Yeah, yeah.
Um,
So I mean, the only reason why I really wanted to the articles really caught my eye was because it's finally something to where if you have been in the small outpatient, small surgery center, smaller office, you're like, no kidding. It's
yeah.
about time the big institutions caught up to the same problem we have,
hmm
which is, where's my money?
Yep.
Where's my money? Like, and it's amazing because my family, other entrepreneurs that I speak to, other business owners that aren't in healthcare do not understand the healthcare business model. And even private equity doesn't necessarily understand the business model either. But the big component that everyone is usually shocked by when they talk to someone that is in the healthcare industry is that your AR looks awful, absolutely atrocious your
Yeah.
first 90 days.
Mhm.
Whereas in most businesses, they receive most of their money on day one, and anything after 30 days, you're not likely going to get it back. It's the opposite for us. We're usually only getting 20% of our money on day one of the claim, and then by day 90, we've received 85%, 70%. 65%, and they punted it to patient responsibility. So it's something to where now it's gotten to such a high number on the AR side that the hospitals can't even fight it. So
Right.
it's very, very, very interesting because the hospitals are feeling it, the unions are feeling it, the insurance carriers are feeling it, the small outpatients offices have been feeling it since COVID, and I would argue even before that. But really, we've been noticing it affecting our hiring since then because the small outpatient office is always competing against the hospital who can pay more,
Right.
always competing against the hospitals and the institutions because they have benefits. Well, I mean, it's a tricky scenario, right? So it's always if I'm in an outpatient side, I'm always competing against them and saying, hey, the value add is that you're not on call. The value add is that you get your normal holidays with your family. The value add is that, hey, you can just see our doctor for little things. Your
Whatever
family
it
can see
is.
the doctor for little things in between appointments, and you don't have to skip a day to be seen. Or you can get paid more, and in some cases, significantly more through a hospital. But again, there's no such thing as a holiday at a hospital. Most hospitals are community based, which those are the ones that are most affected by these games with the insurances, which is why they're running and they're a hospital to run in the red for the record is not uncommon because most of them are considered nonprofit. It
Right.
starts, there's always a point to where it's like, wait a minute, we need to be careful because we're running past where we are normally comfortable, right? A nonprofit doesn't do well if there's profit. So there has to be no profit there, there. And if you're having profit in a nonprofit institution, it's very hard to fundraise, very hard to get grants. So it's always a tricky little game of how do I do this? How do I play with this? Um, when we talk about where the money is and we talk about how do we shift, I always like to try to be, I don't want to be the first SEAL to use a Mr. Wonderful line, right? But I do want to be one of the first ones, right? Because if you look at a herd of any type moving through a field of predators, the
Right.
first one gets picked off, the last one gets picked off. The ones in the middle have varying degrees of success. I don't mind being one of the more aggressive ones because we can move aggressively. But that's my personal risk tolerance, right? Um, and with experience, there's less risk because you have an idea of what's going on. We're not playing the lottery, right? We know our scope of practice that with whatever business you're doing, you know what business model you have. So it's just a matter of being aggressively cautious, right? Like you want to go after the patient population that you want to go after, but you want to do it in a smart way so you don't get burned, right? So uh how do we avoid these cash flow issues is usually a question I get. And
Well,
it
not to
go
just
ahead.
to add to that, Jose, obviously the rising operational cost and, you spoke about it with the ER, the decrease in reimbursements. That's, sort of
Yeah.
forcing these healthcare organizations to make those tough decisions. Obviously, and where that affects the staff levels, directly.
Yeah.
So just
I
to,
mean, you're seeing all the time. You saw it at the MGMA.
oh yeah, yeah. No,
MGMA, what was
well,
my
what was
brother
interest?
told me, my
Yeah,
brother literally told me he was like he got back and he's like, dude, do you have 5 minutes? And I was like, yeah. He's like, I hear all the time about provider burnout, provider burnout. It's all over every news station. He's like, I literally saw administrators coming up to me with their boss right beside them, asking if there's a position with us so they can move and do
yeah,
something else because they're
literally.
so burnt out.
That happened on several occasions. I mean, it was
Which
it was pretty
made me
wild.
laugh.
Pretty
Well,
wild.
it made me laugh, right? Because our regulars on here, I know that
Granted,
they feel a sense of burnout. I know that I
yeah,
feel a sense of
yeah.
burnout sometimes. And it's just a matter of
We've all been there.
admin is the first thing to get squeezed.
Mhm.
Why? Well, because we technically don't generate revenue. Most of the compliance falls on us because providers are awful about keeping up with compliance for the most part,
Yep.
and
Yep.
so somebody has to do it. Okay, so dump that on admin. Hey, we have high turnover. Why? Because the patients are pissed off because their insurances don't cover anything. The providers are pissed off because they're seeing a stupid amount of patients a day just to justify their salary. And then their coworkers are just jaded because they've been in the industry so long and they see that patients aren't being taken care of the way that we're being sold that they are.
Mhm. I'll tell you
So you have high turnover.
another topic that was discussed at NGMA, which I still find interesting, is like as far as AI is concerned, that AI is going to streamline operations, which also could potentially cut jobs. But
So
I feel like we're putting a lot of trust into that. I don't think that's the one all be all solution. Um,
think about
if
AI right now, the way that people thought of cryptocurrency 15 years ago.
yeah,
When
yeah,
you had to mine the Bitcoin, everybody thought cryptocurrency is going to change the world. It's going to change the world next year. It's going to change the world next year. It's going to change
right,
the world next year. We're
right.
15 years in, and you still can't use it everywhere. You can use it in more
No,
places, and there are a ton of crypto coin. Some that are good, some that are bad, a lot of them that are meh, right? AI
yep.
is the same thing. You think it's going to be amazing, but there are certain things that AI cannot do unless you have a robot literally
Well,
doing the
it's
tasks for
garbage
you.
in, garbage out. I mean,
Yeah, with compliance, it's garbage in, garbage out, but your
it's
biggest liability is people.
Yeah.
which is the thing that you have the highest turnover for, which because of the revenue shortage, you have the least financial flexibility. I mean, we're seeing this from the entry level position to providers. Dr. Delgado and I were actually joking. A primary care doctor in Northeast Florida sent in a resume to work with his major with Dr. Delgado's major client, and he wanted $300,000 as a primary care provider, working 40 hours a week, Monday through Friday, 8 to 5. He and I had a giant laugh over this.
Wow.
$300,000. That is a wild number.
Yeah.
Absolutely wild. For those of you that are not in Florida, a normal, still inflated for a lot of reasons, but a more normal rate is closer to that 175 to 200,000 at the very, very extreme high-end market, experience, all the nines, right? Like,
For
so this
primary.
guy was asking for at least a tax of 33%, assuming that he is the best doctor in the world. Yeah.
Crazy.
How do you support that? If I'm an outpatient office, do you realize the amount of patients he has to
Patients, you
see to
got
support
exactly,
$300,000
exactly.
as a primary care? What am I supposed to do with that?
You're
It's a
you're you're at a
specialist. If a
you're on the
specialist is
knees at that
asking for
point.
300, you better be asking how many days in surgery are you going to be?
This is Northeast Florida, you said?
This Northeast Florida.
I guess it would make more sense south, but no.
Even in Miami, even in
I mean, it's still outrageous,
you're
but
talking even in Coral Gables,
yeah,
in all of these rich places, you're not looking at 300 for a primary care. I mean, even on the mental health side, I've had psychiatrists literally asking for 300 to 350 for an outpatient office.
right.
Do you realize the amount of patients they have to see to justify that? 350?
I was gonna say,
That's one of those.
how many would they have to be see in a week to just make it
Well, no.
just to break even? Break even
Let's
on the
just
day.
do this. That is quite literally 170 an hour.
Dang.
At $170 an hour, do you realize how many patients you have to see and get paid for? I mean, you're talking in order to get your money back, right? Because anybody running a business knows the numbers, right? It's not just the salary of the provider, but I got to do the salary of the support staff is in there.
Yep.
My billing costs, if there's billing, my EHR, my rent, my water, my electricity, my internet, my blah 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 blah, all the vendors, all the crap, right? You're really looking that 170 an hour is probably costing you, if they're full time, closer to 250 an hour.
Mm. They better
If
be doing
I'm
everything.
billing
You
Medicare,
can't though.
right? Huh? If I'm billing Medicare, an evaluation is only going to pay me if they're almost hospital level evaluation. And this is Medicare, mind you, which all the other insurances play all these funny little games about how they pay you. Medicare is the most clean about it.
Sure.
You're looking at maybe 180. But that took 45, 50 minutes of their time based on the code, based on the complexity. I got to squeeze in 20 minutes another $100 just to break even. If that patient is a no-show, if the insurance doesn't pay out, I'm not making payroll because of how much they're costing.
Wow.
You know what I mean? Like, and that's not including, okay, my RNs. What are RNs making now?
60,
I've seen
50,
RNs asking
60.
for 80K. I can't support that
Just
in an outpatient office.
base salary?
Yeah. And
Dang.
then benefits. If you include 80K plus the benefits, you're looking at 100
Yeah, easily.
between health and malpractice and workers' comp and You're looking at 100, man. Like, what am I supposed to do with that? There's no way an RN is going to be able to get me my money back in a small office. So what happens? They're gonna move. What happens? The provider's gonna move. Well, what happens when you're paying 170 an hour over here and plus 50K is what? Like 35 an hour? 30, 35 an hour?
Right.
So let's just put 30 at 30, yeah, let's just put 30 an hour, right? Okay. So you're looking at right now $200 an hour just on provider and his support staff, not even the support staff for the RN, which is the MA. And MAs are asking for 20 bucks an hour. And then you got your front desk person who you're paying minimum wage. Are you shocked that you don't have any money left over to pay a good front desk person?
Another, I'm just thinking out loud that another topic they brought up, the MGMA, is APP or yeah, APPs, which is advanced practice providers, which is ultimately it's
Okay.
a nurse practitioner or a physician
Yeah, you're
assistant,
talking about a nurse practitioner, you're talking about a
but
PA. If you're an
you're paying them even
anesthesiology, you're
more, obviously, not
yeah, well, so I can tell you that based on Florida, mind you, every state is different, right? You're looking for mid-levels between 50 bucks, 50 bucks an hour, 50, 60 bucks an hour. Um, Mid-level specialists could be between that, depending on what kind of specialty and the location, all that fun stuff. You could be looking at 55 to 70, 70 super high, but 55, 65, that's a common number. But I've seen some of these people asking as a basic nurse practitioner, like 80 bucks an hour.
man.
How are you charging me $80 an hour? I can pay an MD 95 and I don't have to worry about any of the nonsense. I don't have to worry about
Is
you
that
being
because they come from
supervised. I don't
is that
I don't have
because
to worry
they
about
come
scope
from
of
the hospital level?
practice.
Yeah.
Huh?
Is that because they come from like the hospital level? You know, they're getting paid.
So that's the
That's
thing. The
yeah,
hospitals have been playing this game of, hey, to get you, I'll do this, and they'll do signing bonus, and they'll do that, and the other thing. And then these providers get there and they don't realize, and these private equities are also to blame as well,
sure.
where they're paying these providers an obscene amount of money, but no one is catching on quick enough that they're paying you this obscene amount of money, but you gonna make that money back. You gonna make them
Yeah,
their
they're
money,
gonna
or they're gonna terminate you. So yeah, you may have gotten $300,000 a year, but you didn't make it the full year. You made it 6 months,
right.
and they fired you because you weren't producing enough, which is a very common thing with private equities. The nurses going on strike in hospitals, very, very common right now. I think there's like three of them happening right now all over the US. One in California. I believe it's with Kaiser, actually. Don't quote me on it, but I think Kaiser Permanente is dealing with a nursing strike right now. I think someplace in Massachusetts as well. But there's only so much you can wring from, and until people realize, hey, we have to work within our means. We have to be profitable. We have to be able to pay our bills. You're not going to be able to get a stabilization. You're not going to be
Sure.
able to keep that turnover down, right? Because I guess this is another topic, but why are people leaving? It's not just because of money. Let's be honest. People are coming in because of the high number, but they're not staying because of the high number. Everybody reaches a point where they're like, the money ain't worth this. I'm out.
Yeah.
And then the trick is, how do you add that value add component, right? Like this is where as admin, we have to take a look at our books and say, I can comfortably offer you this, and this is my value add. So maybe we'll do something like, hey, I'll offer you 4 10s instead of 5 9s. Hey, you get an extra day off. How many people love 3 day weekends? I love 3 day weekends. My wife keeps telling me she wants 2 Sundays every week. So you know what I mean? Like it's 3 day
That's
weekends are awesome, right? So okay, cool. Well, how do we get that? How do I get my bang for buck as an admin, but how do I reach the people where they are and where they want to be, right? So this is the conversation that needs to be had is okay, What are you looking for, Bobby? What are you looking for, Susie? And this is the conversation that doesn't normally get had because everybody keeps racing to the top on price. And that leaves less for us to reinvest in the places that need to be reinvested. Places that have been neglected for quite some time. Our HR, our compliance, our just billing assistants. At this point in time, if you're doing billing in house, I don't know how you're doing it. It's becoming too complex. It's too expensive. And if I have a 1 or 2 person billing department, I am constantly worried. If they get sick, if they get fired, if they steal money from me, how long is it going to take me to catch them? Right? Like it it makes me panic
A
when I
lot.
see it. Whereas now, a lot of the EHRs have their own billing component built in. They're making you do so much stuff for quality measures anyways that you might as well just let them do the billing. What's the difference in cost? Some of them are charging you on a per claim, some of them are charging you a flat 7.5%. Okay, you're going to spend more than 7.5 just getting the billing software up and running.
Is
You're
that
going to
worth
spend
doing it more so than hiring a medical billing service
so I am of
at
the
this day and
opinion,
age?
and I've been like, and this has been an opinion that I've been able to back up with actual data since 2011. There is a sweet spot until I reach the size of about 5 to 10 providers. It makes no sense to do billing in house
Hmm.
because any space I take for billing could be used for revenue generating activity alone,
I see.
not to mention the actual cost and complexity of billing for services, especially if I'm in the insurance realm.
So
It just
anything less
doesn't.
than 5 providers, you think in-house is the way to go.
If it's less than 5 providers, there's no reason to have billing in house. None at
But
all.
there's resources like now, or I guess nowadays, where you can do it through your EMR
Yeah,
platform
you can do it through your EHR, but
to
then you're
make
not
life
really doing it
easier.
by yourself because the EHR is doing most of the heavy lifting, which is sending in the clean claim, which is where the exchanges come into play because if the exchanges work properly, they're supposed to scrub the claims before it goes to the insurance. But that's a load of crap too. But we're not going to talk about the exchanges and their built-in tax that they've had since the late 80s. That I don't know why they're even necessary now, but whatever. Anyways, so where's the money? What do we do? Right. So if I charge a patient $100 for the visit, okay, I need to know what my numbers are. How much did it cost me for my provider to see that patient? How much time did it take? Because then I can break down my costs from there. Alternatively, you can go by the hour because that's usually a little bit cleaner, right? So I can say, hey, my provider cost me, let's just put a number to it, 100, right? And then need to get that. Not to mention, let's just attribute, partial one bill of one front desk admin person, $20 an hour. So we're looking at what did I say, 155 an hour, and then if we attribute some of the other stuff, probably 175 an hour, more or less is
Sure.
what I need to come to, right? So how do I get that 175 in that hour? That's what I'm looking at. And obviously multiply that out based on, how many hours in the week you're seeing patients, and you'll find where your holes are, right? Either I'm paying too much, I don't have enough patients, I'm not getting the money that I'm expecting back from the insurances, which means it's time to address the elephant in the room, which is it worth me taking the insurance? Because if I have, let's just to put a number, my provider sees 25 patients in the day, right? Let's do 24 because it breaks down into 8 hours. 24 patients in the day, which is not an uncommon number. And so
Sure.
he was busy. He
Yeah.
was busy. That basically breaks down to a patient every 20 minutes.
Yeah.
That means that means every 20 minutes, if we use that 175, we're thinking that we need to get back $60 per patient visit. Does that make sense? But that's
Yeah.
just the cost. Now, if there's overruns, if there's this, there's that, there's profit, we're probably looking about we want to be at that 300 to 350 an hour. If we think our cost is 170. So now we're at, okay, I need $100 visit. Okay, well, hold on now. Maybe I do need that mid-level because instead of $100 an hour, I'm paying $50 an hour or even $60 an hour. Because now that number just moved my needs down from 170 to 130. That's a big difference.
Oh yeah. Yeah.
But if I keep that revenue at 350, then all of a sudden I just built my profit in. Does that make sense? So
No, it does.
this is where
Fine
you
line.
get a situation where you have an office that is 4 providers, but it's one MD and 3 mid-levels. Because the MD is supervising the mid-levels are cranking them out. Whether it's a PA or an MP, they're just cranking patients out, right? So then you have a situation where, okay, now I'm pulling from multiple places. I've got multiple sources of revenue, but this is where things start getting complex because then we're like, oh, well, we're spending money here, we're spending money there, we're spending money there, we're spending money here. Hey, maybe we've got a second location. So now it's a second set of money that's going out. You know what I mean? So this is where practices and hospitals start getting they start getting hungry with their eyes rather than with their stomach, right? Like they start seeing all of the possibilities, and this happens to everyone at every level because you're just like, oh, well, this is going to be easy. I just need to do A. I just need to do B, C, and D, and all of a sudden we're good to go,
Sure.
right? Well, um, Monopoly never works that way. And if
No,
you
that
haven't been kicked in the teeth yet, realize that Monopoly lesson yet, you either haven't played enough board games or you haven't been paying attention. Pay attention to your business.
I was gonna say,
So
what do you think about these clinics that are, they're adding services, right? And they're billing for them, and those services, are no longer eligible to be reimbursed. I've,
my
uh,
okay, I am huge. I'm a huge proponent of any way. Again, it goes back to how do I get to that magic number? Profitability.
right,
Any way I can increase revenue without increasing my labor costs, I am 100% in. Which means what? It means maybe we're doing a few more services in the office that the RN can do, but the provider is on site. Or maybe we're doing a couple of tests here and there. Or maybe we're doing some ancillary services that bring in other revenue. Maybe I'm bringing in a PT once a week. PT's doing stuff on site. They don't need much space. It's essentially working out the patients. I can bill for that. And bingo, bango, we're out of here, right? But it's
yeah,
more patients. Or it's maybe I'm doing an infusion center. Maybe if since I'm in mental health right now, we're working with Spravato. Where hey, okay, my provider has to watch the patient, puff, puff, patient goes, hangs out for an hour and a half in a dark room. As long as I can put them in a dark room, but still turn that exam room around, all of a sudden, how long I can quantify how long does it take for my provider to watch that person take the medication?
right.
90 seconds? 2 minutes? But I get to bill an office visit for that? 100% because now it makes sense for me to double book 9 o'clock because it's one person for med management, one person for the ancillary service, but the ancillary service takes 2 minutes. So patient as the provider is literally just they're NASCARing this real quick. Hey, let me watch you do this. Okay, deuces. Let me know if there's a problem. Next one. All of a sudden, I just added, and even if it's just one more visit an hour, all of a sudden, even if they only pay
No,
me
it's a
50
big deal.
bucks,
It's a big deal.
it's a huge deal. It's a massive
Yeah,
deal. But this is where you start seeing all of these different plays where all of these providers are bringing in ancillary services. If you're not bringing in ancillary services and ancillary providers, I would highly recommend it. If you're one of these providers that has been around for a hot minute, as in the minute when everybody bought their own building and built their dream office, and now they've got this building, you need to start looking at the model where you rent out to providers who got burned by a hospital but want to practice medicine. You become essentially a hotel. You become
Sanctuary.
essentially well, it's not even just a sanctuary, but you become essentially you're renting out space. You're
Yeah.
subletting to other providers 1 day a week, 3 days a week. Hey, that allows for you to go and do something else, or maybe even get quality of life. Because if I can bring in a specialist and they only need half the space, and I got to go and see patients at nursing homes anyways, I'm going to pick the day that the specialist is in the office because my team can still come to the office and get paid, but they're working with another provider. So that provider is subsidizing my cost. And I get to still go see patients at the nursing home, which I got to do anyways. Or I got to go do rounds at the hospital, or I got to go to the ALF, or I got to go to hospice, or I'm in surgery that day. So all of a sudden, I may be in surgery, but there's a provider in there seeing patients. So all of a sudden, we're double dipping,
Right.
right? So this is where we've got to be super efficient. And the larger hospitals are catching on to the concept, but they're doing it late. And one of the ways that they're doing that, and I don't know about everywhere, but here in Florida, they're doing a lot. If I'm a hospital, because I need to make sure and be profitable, get patients moving in and out of the ER for quality measures and all that fun stuff, they're setting up satellite urgent cares in a bunch of different places. So
All over the place.
now instead of just these standalone urgent cares, right? You have the urgent care that's attached to the hospital. So you go into that urgent care, and if it escalates to the ER, then they will escalate you, and you don't have. And the convenience for the patient is I don't have to fill out all that paperwork again. I've already been triaged, so it's just a non-ambulatory service takes me to the hospital, which then allows them to bill for also the transportation unless you can transport yourself. But an urgent care is easier to operate and it's cheaper to operate than staffing the crap out of an ER and then getting complaints because you have an ER where patients are in the hallway. You're going to charge me full price while I'm in the hallway? It's wild. And I've seen it, and it still happens on a regular basis, at least here in Florida. I don't know about
I hear
everywhere
I
else.
hear
I haven't
stories
been
all the
everywhere
time.
else. Huh?
I hear stories about that all the time. It's like and half the people in there are just feverish or just have symptoms that they can
I don't
see their
I
primary.
don't care. I
Yeah.
don't care. You
Yeah.
have a major compliance problem when you are putting a
Yeah.
patient in a hallway and asking them a bunch
No, no,
of personal
absolutely. I
health
agree.
information
I don't
questions.
disagree.
You are crazy.
I don't
Unless we are
disagree.
literally in that disaster mindset or disaster situation, there's no reason for it. None at all. So that's a
Yeah.
whole nother, but again, if I can bill for it, which the hospital's going to do,
Gonna do either
I'm
way.
not going to expand it because I
Yeah.
have my sunk cost into the ER. And most of these hospitals, it takes millions of dollars to add on more rooms. Meh. What's one or five patients or 10 patients a day in a hallway? Now they're going to get admitted
Crazy
or
way
they're
to look at
not.
it, but yeah.
I mean, that's not caring about patient care.
Right.
That's putting unnecessary stress on the support staff. And this is the stuff that nurses get pissed off about. This is the stuff that the nurse unions actually have a bone to pick, and it's a legitimate point. But it's how do we get there? What do we do? Let's take a look at our revenue sources. So if we know what money we need to come in, right? How quickly are the insurances paying us? Are they paying us at contract rates? Is it even worth to have them? I've literally seen situations the last 6 months where providers are dropping insurances in the outpatient offices, not just the hospitals arguing and negotiating, but these are outpatient offices that are saying it's not worth it for me to take this insurance. Yeah, they may be giving me 20 patients a month, 100 patients a month, But the problem is I'm getting paid like it's half that. So why add the labor costs and the stress of trying to fit 100 patients or 20 patients or 10 patients when they're paying me half of that?
Right.
It doesn't make any sense because I want to see patients. I want to make patients get better, and the insurances leverage that against us. Well, stop playing. At
Cash
some
only.
point, we all have to sit there and
Cash
say,
is king.
when is enough? At some point, everybody gets to that spot. When is it going to be enough? When are you going to go and say, hey, I can't take this insurance anymore? I will take you as a patient. I will give you a receipt. You let me know what you need. You can bill your insurance and get reimbursed, but have a nice day. It's not worth it. I'll tell you right now, if you're billing the VA or TRICARE, you're wasting money. Absolutely wasting money. The VA and TRICARE on their website has a way for every single patient
The
to get
bill.
reimbursed for services. And they will get reimbursed. It's up to a set amount, but they will get reimbursed 100% for medically necessary, obviously. But for medically necessary, up to like I want to say it's like $200. So if the services you're providing are under that number, there's no reason for you to bill. But you're losing 8% on billing. So let's say it's 200, you lost $16. Boom. Just because you decided to bill in your office. Oh, hey, guess what? They have a copay. Let's say that copay is $50. It's 25%. Well, guess what? You just paid a credit card processing fee. Boom. You just lost another couple bucks. Let's just say that it's just to put a number to it, it's 2%. So what are we up to? You've already lost. You've already lost $20 of that 200. And you still haven't seen the patient. You know what I mean? Like it's and you still haven't played the 90-day game. Or patient, I will take that credit card from you. I'll take that debit card. I'll take cash.
Yeah.
I pay that
Yeah.
one credit card processing fee, but it's $200 rather than $25 or $50. And they can go argue with the insurance. And the insurance is incentivized to keep them happy. Why? Because if not, they stop paying
They stopped
premiums.
paying the premium. Yep.
You will be amazed at how quickly and conveniently patients can submit their own bills and get reimbursed. You'll be shocked. Absolutely shocked. All it takes is a little bit of education. Patients are not dumb. You're a patient. I'm a patient. My parents are patients. Your kids are patients.
Yeah.
We just need to educate the market, which is what Ray and I strive to do here. So, I mean, where's my money?
Where is the money?
You have all of these hospitals. All I'm saying is when everybody's freaking out about money and stress, it means that you're not alone, which is an amazing amount of catharsis, at least for me, because it makes me feel like I'm not crazy. I'm just tired like everybody else. All right. Now that I know that this is a widespread problem, I can stop focusing on the issue and start focusing on solutions. Now, what is the solution? Well, I either need to bring in more money or change the way I bring money. That's the solution at the end of the day. Now, once we've decided, and you may not decide right out of the gate, maybe it's a combination of both, but then it's okay. With that, with those two, with that tree in mind, what are my resources? What are my requirements? Every office has a different requirement. Maybe there's some stuff that I can move here, or maybe there's some stuff that I can move there, or maybe by switching this contract or renegotiating that, we can. I mean, right now with this economy, so many people are renegotiating contracts that are multi-year contracts. The city of Chicago is renegotiating contracts with
Saw
everybody.
that.
You saw that?
Yeah.
They're The city of Chicago had the stones to mail every vendor and say, "Hey, we're the city of Chicago. We need a 3.5%. I don't care what we signed."
I saw it.
If the government can do it, why can't we? Every contract has an out. Help me, or I'm going to your vendor or your competition.
Yeah.
This is, hey, it's not personal. This is business. But in order for me to stay alive, I've got to make sure that my team is running smooth. My team is running efficiently, that they have the tools to do their job. It is amazing how much people don't realize that turnover costs money. In
Certainly does.
between the stress of finding a person to fill that spot, in between
The amount
hiring
of
the new person, training the new
training.
person. I mean, just the outlay on the compliance requirements. Ray, would that be compliance? How long is it going to take a brand new person to complete all four trainings?
It takes about an
OSHA,
hour.
HIPAA,
Takes about an
privacy,
hour per
security, and
course.
OIG.
4 hours
Hour
in
per
total.
course. You've literally pissed away a half a day.
Yeah.
Assuming that these people are paying attention and can pass the test the first go. A half a day
Very
on
true.
just compliance. Then you've got another 45 minutes based on, hey, this is the paperwork for hiring and payroll and benefits and getting them set up with the EHR and then the
Hep
training
B,
on their EHR and then
the
training
Hep
on
B that we
their
just talked
spot.
about, you know,
Yeah, but you see what I'm saying? Like this
all
is just
that,
a factor of
all of it.
so many things. You have situations where I've literally seen non-providers have to get trained for 2 weeks. You just paid somebody an entire payroll cycle and they haven't done their job yet. That is wild.
I
Maybe
mean,
we need
that's
to address that. How long
yeah.
does it actually take us to do all this stuff? Is it necessary for them to do all of this stuff? Having clean job descriptions is huge for that. Having a clean onboarding HR process is huge for that. Now again, you can be a complete cynic about it and say, no, we don't offer benefits. So it's just payroll and the EHR and how you're clocking in and clocking out. Deuces. But I'm still gonna have to shadow somebody because I gotta know what the EHR this is. Unless I've worked on that exact EHR in my last occupation
Right.
or my last position,
Otherwise, it's not
I'm,
gonna
I'm gonna have
it's not
I'm
gonna
gonna
do
be
you any
spending
good.
time. Yeah, I mean, you're gonna have time. If you've worked with one EHR, with switching EHRs usually is not that difficult because there's a standardized list of operations. The difference is learning the UI, right? It's like going from one Windows to the other Windows, or at worst, Windows to whatever crap Apple calls its environment, its version of Windows, which I've seen even be Windows, but doesn't run as well. I mean, whatever. Anyways, like it's jumping from a Droid to an Apple.
Sure.
You know, it an Apple and a Droid are going to do the same thing. They're going to make phone calls. They're going to get to the internet. You're going to get to your apps, but the UI may be slightly different. You may like one, you may like the other. Really doesn't matter. It's the same crap at the end of the day. You just got to figure out what that UI work is, that workflow is, and that can take time. Some people pick it up super fast. That's that tech literacy, which is huge for me now. If someone is not tech literate, there's no point in hiring them. In today's healthcare environment, if you're billing any insurance, there's no point. If they're not tech literate, there's no point. Everybody runs an EHR now. If you're not running an EHR, then you don't need tech literacy. Right? And there's different
Absolutely.
levels, just like everything else. Do I need a high level of tech savviness? No. But I need you to be able to check your emails. I need you to know how to attach things. I need you to know how to operate an EHR, operate a computer, know that half the time I just have to turn the computer off and then turn it back on and it fixes itself, right? Like but if it's something to where any little thing makes you freak out and then you have to call me to waste my time as an administrator because hey, the computer did IT did a backup and wiped all the cookies. Okay, well then
Restart the computer and turn back on, let the updates roll through.
When you get back onto the EHR, now you may have to do dual factor authentication
Yeah.
because a
Yeah.
lot of EHRs are pushing out multi-factor right now because of all the other crap. Well, that takes time too. Now it's a question of how am I doing that? You know what I mean? So there's always more crap that's costing us money and time. We just got to figure out how can we guess where we're going to be and the things that we need to do and streamline the processes, right? So we're here to help. Epi compliance can help you on the compliance side, which is a massive piece. The only thing Epi compliance cannot do is make your staff not be dumb.
We give you the
Sadly, that is
tools, you put
still
the
on
tool
us
in
as
motion. That's what I
administrators.
always say.
Yeah, like the only thing that Epi compliance can do is teach common sense, which, you know, I know, Tracy. I know. I threw that in there for all of you guys,
Yes.
you regulars, like Epi compliance can't do that. But a consultant can help you out with some of that stuff. Hey, if we know it's a no, common sense is a superpower nowadays. There's certain ways that we can make things to where I mean, some of these guide dogs are smarter than some of the people that are applying for positions. That's okay.
Yeah.
If I know this going in, I can protect the practice by really setting up firm guardrails. That takes time on my end on the front end, but on the back end, if I can keep that person in those guardrails like a bumper to bowling alley, I don't have to worry about it. Right? So it's something to where know what your resources are that are available to you. And sometimes I can go and make that position, hey, all right, that position can be replaced, or hey, that position can be moved over. So it just kind of depends on what you're doing. But and what that position entails. Like, hey, maybe I need more space to do revenue. Maybe billing and HR don't need to be on site. Maybe they need to come in once or twice a week so we can have our meetings about different things, but maybe they can work from home. So everything needs to be evaluated. If you're not evaluating your business, don't worry, your revenue is evaluating you.
That's a good point.
I definitely don't want to be black-pilled about this stuff. The articles are a little bit more black-pilling because they talk about how in danger hospitals are. I don't care. I don't, and the reason why I don't care is because they just got a 2% bump from Medicare. They've always been bloated administratively, and there's a ton of waste in all these hospitals. I don't want to hear it. They need to learn how to operate like outpatients do, outpatient offices do. If we don't operate with profit, we close. That's it.
I
So
agree.
figure it out. If not, somebody else will figure it out for you. Like it's just kind of how that goes, right? So protect yourselves.
Don't get replaced.
Yeah, I mean, but again, the easiest way to not get replaced is to increase the value you bring,
Yeah, absolutely. Absolutely.
right? So if you're concerned that AI is going to replace you, maybe you're not doing something necessarily that crucial. Here's an example. Coders have been worried about getting replaced since EHRs came out. And they're 100% right. Because you don't need a coder for everyday things. However, if I'm bringing in ancillary services, this is where a coding consultant really comes into play. Hey, what are the codes I can use for this? Hey, does this insurance like this? No? Okay. Well, we will do this service this way, not that way. I can go to every specialty and every office manager, and every office manager worth their salt will tell me, can bring up immediately one example where if your office does this service in this way, the insurance will not pay. But I make one stupid tweak, push one button, and all of a sudden it pays out.
What's
There's no
that?
reason for it. It's the
It's
same crap. For mental health, it's quite literally some of the insurances won't pay for telehealth unless we put the modifier for telehealth. They're like, it is the stupidest things. I've seen ones where they will do they will do for quality measures. It happens all the time. If I don't click it, it doesn't exist, right? So if we talk to the patient about smoking cessation or diabetes and we didn't put down that we did that counseling, they won't pay for it. It won't count for the quality measure. The tweak is stupid, but
Little
it makes
things.
us do it, right?
Yeah.
I mean, every specialty has this stuff. There's ones in regards to prior auth. Like if you know the prior auth is going to be needed, most office managers are just like, look, just get the prior auth ready because Dum Dum Insurance is going to ask for it. So let's just have it ready. So when they ask for it, or we pre-send it, so that way it's not even a problem. Oh, you didn't receive it yet? That's funny because my fax says you received it 2 weeks ago. Don't bother me. Pay me. Because it's already been 30 days since we set the claim. you know,
Yeah.
like it's the argument that every office manager is either laughing or banging their head against the desk right now because they just did this.
Hopefully not Tracy.
No, Tracy definitely did it. Tracy's definitely done it. She's probably laughing because we've just had this
I was gonna
conversation,
say,
her and I.
at the end of the day, especially as an admin, you have to be adaptable, because there's just
You
changes
gotta be adaptable.
for it. Things
And
are always changing.
yes,
There's no way around it. You have to be.
yes. So there's three things that I would recommend for every office manager nowadays. One, find something that you can do while you're on the phone waiting for answers. Whether it's, something to keep your cool, whether it's, busy work, whatever, but make sure that you've got something there. And the reason is because these phone calls always piss us off. Because it's always something stupid. Second thing,
That's
make
a good
sure that
point.
you have like on the border of your desk something soft. So when you slam your head against the desk because you're mad about the conversation, you don't leave a mark on your forehead when you have the rest of the day to work, right? You don't get concussed, right? And then finally, figure out what your numbers are. So that way you can figure out where your holes are. A lot of times I have seen offices, you can't cut yourself into profitability, but you can cut to sustainability and then build the profit. Does that make sense?
Nah, it does.
So I guarantee you, if you haven't looked at your vendor contracts lately, there's probably something out there that you can renegotiate at home. If you're at home, if you're one of those people like I am, every year I renegotiate my internet. Why? Because my internet carrier
I just
always has a
freaking
new
did that.
package.
Literally, just did that with AT&T.
So if you do it at home, why wouldn't you do it at your work? Stop it.
Yeah, no.
Stop it. It's the same thing. The only things you can't renegotiate are your
They
taxes.
think that, well, that's the thing. They think that you're not gonna reach out, but
That's
listen,
the point. It
listen,
doesn't
you see it.
incentivize them to.
No.
There's no
Yeah.
reason for them to reach out to you unless they're trying to upsell you, which is when you go and say, no, no, no. If anything, you just change the price to make it lower. Either give me a new contract with lower price or I'm leaving to your competitor that's going to give me that lower price anyways. So the cell phone carriers are constantly racing.
Yeah.
Hey, I'll give you a new phone. Why? Because this phone is $800, but I'm going to keep you for 3 years. I will make my money back. So that's what we got, though, guys.
Now, if anybody has any questions or concerns, please feel free to put it in chat. And as always, you can always reach out to me and Jose directly, and we're here to
Yep, and
help.
the articles are there. So in case you want to read and have fun, there's not one state where there is not a hospital freaking out or hospital system freaking out about money. So feel better.
Yeah.
The entire industry is feeling it.
I did put next week's webinar topic here in the chat. You guys will receive an email with that correspondence as well and the registration link. But we are going to be interviewing a partner of ours. His name is Rick Acevedo. He works for iTech Plus, which is a IT company based out of Orlando. And we're going to be interviewing him. And topic of discussion is going to be around employee training and incident response. So looking
Perfect,
forward to
perfect.
that.
That'll be fun.
Threw his website in there as well if you guys want to give him a look. Um, but yeah, I'm looking forward to that interview. And I don't think we've interviewed an IT guy yet, so
No, no, we
I
have not
think
done IT
this will
yet.
be a first. And as always,
That'll be fun.
if you guys have any topics you'd like us to discuss or anything that's going on in your clinic or anything that you'd like us to shed light on, let us know. Be
Yeah,
very happy
absolutely. It'll be fun.
to put something in the books. We are working on the April schedule as we speak. So, well, we got one.
Perfect
We
then.
got the first week covered. What workplace violence is what we're going to be talking about.
Yeah, workplace violence is on a high.
So,
You'd be shocked by some of the numbers coming out from OSHA.
yeah, it'll be interesting to go over. Looking forward to it.
Yep, yep.
Cool.
So,
All right, Jose. Well, as always, appreciate your time. Appreciate everybody tuning in
yeah,
today. Just be on the lookout. As I mentioned, you will receive some correspondence with obviously a recap of today's session, the registration link for next week, and also the YouTube video for this session as well. If you'd like to share it with any of your team members, maybe your physician, anybody that you think this would be beneficial to, please do. And other than that, we'll see everybody next week and we'll talk soon.
have a good one, guys.
Take care.